Hello, and welcome to the first Pharmacy 15. The primary goal of these mini lectures is to review the interventional pharmacologic agents used in nuclear medicine exams. Interventional medications are used to alter physiology and measure the response. Interventional medications enhance the physiological process being evaluated and can increase the procedure's sensitivity and specificity. These Pharmacy 15s will also review a few of the adjunctive medications, which are medications that are administered to alter a patient's condition in some way without deliberately influencing the physiologic response being examined. For example, we give Lugol solution to block the thyroid and reduce radiation dose for procedures using iodine. So let's get started with the first set of interventional drugs used in renal and cerebral imaging. We're going to start with three drugs used in renal imaging: furosemide, captopril, and enalapril. Then we will discuss one cerebral fusion medication, acetazolamide. There is a little catch here. Although acetazolamide is used for cerebral imaging, it's actually a diuretic, which is why it makes sense to cover it in this Pharmacy 15. There are two main classes of renal medications we're going to talk about: diuretics and ACE inhibitors. Diuretics in general increase urine volume. Angiotensin-converting enzyme inhibitors, or ACE inhibitors, are a class of drugs used to treat and prevent high blood pressure, heart failure, and kidney disease. So let's talk about furosemide first. Furosemide is a loop diuretic that increases the volume of urine by inhibiting the reabsorption of sodium, potassium, and chloride, predominantly in the ascending loop of Henle. Ergo, they're called loop diuretics. And you do remember the loop Henle, don't you? The beauty of loop diuretics is that they have rapid onset of effect and they have potent diuretic effects, which are short in duration, making them well suited to produce physiologic effect for renal imaging. Furosemide is used to increase the urine flow rate, which allows us to differentiate between an obstructed and an unobstructed kidney. The ability of the kidneys to significantly increase urine production is key to diagnostic accuracy in diuretic renal scintigraphy. Increased urine production is a function of renal function and hydration status. Diuretic renal scintigraphy is based on the principle that under physiologic conditions, urine may be retained in a hydronephrotic renal pelvis due to one of two reasons. One, because there's an anatomic obstruction preventing the outflow of urine, or two, because of the reservoir effect. The reservoir effect is when urine pools in the dilated renal pelvis until enough urine accumulates to spill over into the ureter. In other words, the reservoir effect is a pseudo-obstruction that can mimic mechanical obstruction. The reservoir effect can be overcome by high flow conditions such as what occurs with diuretic administration. Ding, 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 ding. Thus, for diuretic renal scintigraphy, we evaluate the washout of the radiopharmaceutical from the collecting system. If the furosemide administration drains the urine from the collecting system, then there's no mechanical obstruction. All right, let's get down into a few nitty-gritty details. The onset of action, where it starts working within 5 minutes, with peak activity seen between 15 and 30 minutes after administration. However, it can have significant effects lasting 2 to 3 hours, so you might want to warn your patients that have a long drive home. The standard adult dose is 20 to 40 milligrams, and the pediatric dose is 0.5 to 1 milligram per kilogram. Furosemide is administered intravenously over 1 to 2 minutes. There are a number of protocol variations for when the Lasix is administered. If you want to learn more about it, or if you get a job in a lab using different timing, there's an article up on Moodle. Usually, most labs follow the Santa Fe consensus recommendations, where 1 to 2 minute dynamic images are required for 20 to 30 minutes following MAG3 or DTPA administration to evaluate renal parenchyma function, urine outflow to the collection system. If there's a radiopharmaceutical retention in the renal pelvis, the patient gets up, walks around for 1 to 2 minutes, goes to the restroom, and lays back down. The furosemide is given over 1 to 2 minutes, and dynamic images are required for an additional 20 minutes. Lasix is contraindicated in patients with anuria, which is the absence of urine production, or less than 50 mLs of urine per day, where the normal urine production is about 800 to 1,200 mLs per day. Other contraindications include hypersensitivity to Lasix, sulfonamide hypersensitivity or a sulfur allergy, sodium or fluid depletion, in other words, the patient's dehydrated. Adverse reactions include nausea, vomiting, diarrhea, headache, dizziness, hypotension, blurred vision, and dehydration. Duh. Now let's talk about ACE inhibitors. As I mentioned, the kidneys play a crucial role in the regulation of blood pressure. The kidney's role in blood pressure regulation occurs through a negative feedback loop. That feedback loop is way too complicated to cover in a 15-minute video, and truthfully, that whole feedback mechanism loop has always confused me. It's enough for you to know that a decrease in blood flow through the kidneys due to stenosis leads to reduced glomerular filtration. Angiotensin-converting enzymes then convert angiotensin 1 to angiotensin 2, causing vasoconstriction, which increases blood volume, leading to increased blood pressure. If there's a hemodynamically significant stenosis of about 75% or so, the feedback loop kicks in to restore glomerular filtration and causes hypertension. Said another way, if you have renal artery stenosis, your body increases blood pressure through vasoconstriction to restore flow through the kidney for filtration. Got it? Captopril inhibits angiotensin-converting enzymes to decrease blood pressure. It has a rapid onset of action and short duration of effect, making it an ideal interventional drug. The blocking conversion of angiotensin 1 to angiotensin 2 limits the compensatory vasoconstriction, leading to decreased glomerular filtration in a kidney with hemodynamically significant renal artery stenosis. In nuclear medicine, we use captopril to assess the function of the kidneys and specifically to identify renal artery stenosis by observing how blood flow to the kidneys changes after captopril administration. A significant decrease in renal function following captopril suggests the presence of renal artery stenosis. The onset of action of captopril is usually within 15 minutes, with peak action seen at 45 to 70 minutes. The duration of effect can last between 6 to 12 hours. Captopril causes vasodilation in healthy kidneys. In stenotic renal artery, the ability to compensate for vasodilation is limited, causing a disproportionate decrease in blood flow to the kidney. In a normal study, both kidneys show similar or minimal change in function after captopril administration. However, if there is renal artery stenosis, there will be a significant decrease in the function of one kidney compared to the other after captopril administration. Patients should discontinue therapeutic ACE inhibitors for 3 days prior to the study. 25 milligrams of captopril is given orally 60 minutes before the renal scan. If there's no noticeable change in the blood pressure, 50 milligrams may be needed. Some labs crush the tablet to increase biodistribution. When patients are given captopril, the blood pressure should be monitored for 60 minutes and the patient should be kept hydrated with approximately 1 liter of water. Captopril is contraindicated in patients with known hypersensitivity to captopril, angioedema, high renin levels, dehydration, salt depletion, recent dialysis, or aortic stenosis. It should be avoided during pregnancy. It should be used in caution with patients with scleroderma, lupus, depression, diabetes, or liver dysfunction. The adverse reaction to a single dose include hypotension, dizziness, tachycardia, chest pain, loss of taste, fever, and a rash. And now let's talk about enalapril. Enalapril is also an ACE inhibitor that works essentially the same way as captopril and has the same mode of action: indications, contraindications, warning, precautions, and adverse reactions. The main difference is that it is administered intravenously, eliminating problems such as variable absorption and delayed onset of action, as is seen with captopril. This allows for a more complete response and shorter study time. The onset of action of enalapril is 15 minutes with peak activity at 60 minutes. The dose is 0.5 milligrams per kilogram of body weight, diluted in 10 mLs of saline and injected intravenously slowly over 5 minutes. By administering enalapril slowly over 5 minutes, adverse effects can be minimized. The maximum dose is 2.5 milligrams. If the patient's blood pressure drops more than 30% from the baseline blood pressure, saline should be infused until the patient's blood pressure returns to baseline. Images can be obtained 15 minutes after enalapril administration, and a response is noted by changes in the blood pressure. Finally, let's review the one cerebral medication that is also a diuretic. Remember diuretics I described 5 minutes ago? Acetazolamide is a weak diuretic and is used to assess cerebral blood flow and cerebral blood flow reserve by imaging at rest after vasodilation. It's a lot like a myocardial perfusion imaging with vasodilation. Decreased flow reserve does not demonstrate the same increased flow in response to vasodilation as areas with normal vascular supplies. Said another way, normal vessels readily dilate while diseased vessels do not, revealing differences in blood flow between regions of normal and decreased vasculature. Of note is that acetazolamide is used for a plethora of other indications such as glaucoma, altitude sickness, or Meniere's disease, just to name a few. The primary site of action is the proximal tubules of the nephron, and the mechanism of action is really complex and, again, not possible to cover in a 15-minute lecture. The onset of action is not immediate, with a slow increase within 30 minutes and peak activity seen by 2 hours. The duration of action is 12 hours. Acetazolamide increases cerebral blood volume by 9% and cerebral blood flow by 50% in normal vascular territories. Cerebral imaging with acetazolamide is used for cerebral flow reserve in patients with transient ischemic attacks, strokes, carotid artery stenosis, and to differentiate vascular dementia from other causes of dementia. The standard dose is 1 gram of acetazolamide diluted in 10 mLs of sterile water, which is administered by slow IV over 2 minutes. The administration is done 20 to 30 minutes before the administration of the tracer. There's a ton of contraindications and precautions. Acetazolamide is contraindicated if the patient has sodium or potassium depletion, hyperchloremic acidosis, Addison disease, adrenal insufficiency, and marked hepatic or renal impairment. It should not be used in patients with hepatic cirrhosis because the risk of hepatic encephalopathy, or in patients with chronic closed angle glaucoma, whatever that is. It should be used in caution with patients with known kidney or liver disease, diabetes, gout, lupus, hypertension, and pregnancy. Luckily, the adverse reactions tend to be mild and transient, and they can include tingling in the extremities and mouth, blurred vision, headache, dizziness, confusion, flushing, nausea, tinnitus, changes in taste, and urinary urgency. Remember, it's a diuretic. Most of the adverse effects can be avoided by slow infusion over 2 minutes. So there you have it, the first Pharmacy 15 on renal and cerebral medications. Don't forget that on Moodle there is a summary document and a template for you to create flashcards to help you study. So keep studying and good luck.